I'll be talking to you on basics of evolution of insulin and its translation into practice. I don't have any declaration to make. We are closing on to the 100th year of insulin discovery and treatment. The MacLeod was a young scientist. He was a physician surgeon at the age of 22. He went to MacLeod and asked for a proposal on working on pancreas extracts on diabetic dogs. And MacLeod accepted it, and he was assisted by a student, assisted by Best and Collip. Collip was a biochemist, and he helped him in purifying the insulin. Thus, the first insulin was born in January 1922. Since then, we are almost closing to 1 century. 2022, we will be celebrating the 100th insulin injection. The commercial production began in 1923, when 23 to 1950 saw the innovation of insulin therapy mainly in the purification and concentration and modification in the duration of treatment. Hence, this NPH and Lente were born. So from 22 to 50, the modification in the duration of the action was mainly concentrated upon. Till 1970s to 80s, nothing much happened until the insulin gene was discovered rather, and then onwards the world didn't look back. The human insulin was manufactured commercially, and as we all know, is available to all of us today. In 1990s, we went still further, and insulin was born. The Lispro was born in the first step, followed by many other companies which produced analog insulins. So then onwards, people looked at again the technology to increase the duration of action. So a lot of concentrates, mixtures, and finally the alternative route of administration also was born in the form of nasal insulin. Soon probably we'll be seeing nasal insulin, and to help these administration, lot of devices were helped. So right from the pens that were available in 50s, 60s, today we have the simple pens which are available to us. Then we have the pumps available. So the entire time, the outlook on diabetic care has changed. The only question we need to ask is, has it changed the outlook of diabetic patients? That's the one thing which we require to look at. Okay, this is the timeline from 1920s to 2020 and how the whole insulin saga has evolved over a period of time. Yes, we all know that insulin is produced by the beta cells of the pancreas. It is stored with the zinc as hexamers, and then there is a stimulus like food. These are released into the circulation as monomers. These monomers enter and monomers are the basic units which are required to initiate action of insulin. Okay, and this is how with the food the insulin is released. They have first phase and second phase of insulin. Insulin is produced both as a basal state and during stimulation. Hence, it is secreted at the rate of 0.5 to 1 unit per hour. But when with the food, this production goes very high till the blood sugars gets well controlled. This is a beautiful feedback mechanism. Thereby, the insulin initiates action both by supplying alpha cells, the glucagon, and the entry of the glucose into the cells and the storage. Thereby, the blood sugar is homogenized. And all that we are looking at is how to mimic this phase of insulin into our patients who have a insulin resistance or no insulin in their body. That's exactly what we are looking at. And this is the action. Though the half-life of insulin is very short and it is destroyed in the liver and the kidneys, within that period, it does a lot of work in the liver and in the skeletal muscles. In the liver, it suppresses the gluconeogenesis and produces triglycerides, and even in the fat cells, it produces triglycerides. Therefore, it stores fat. When it comes to skeletal muscle, we know that we have receptors in the skeletal muscles. These receptors are needed. Without these receptors, insulin cannot enter, and the insulin binds to these receptors, and there's a tyrosine kinase which gets phosphorylated, which other substrates And there are two important PI3K and MAP kinase pathways. Ultimately, these pathways are responsible for proliferation, differentiation, protein synthesis, lipolysis, gluconeogenesis, glycotransport, and production of transporters. These transporters are very important because these, when they go to the cell space, the glucose gets attached to these transporters. From these transporters, the glucose gets internalized. This is how the blood glucose gets reduced in the body. This is a beautiful mechanism which the body has through the glucose transporters. So this is a little complicated diagram. Ultimately, it says the same thing, but how beautifully the glucose transporters go into the, and this all happens in the skeletal muscles. What is the difference between exogenous and endogenous insulin? There are beautiful diagrams which shows that there's a insulin which directly gets secreted into the total circulation, and it has a pulsatile way of production, and it has a feedback through which it either gets stimulated or gets suppressed. But unfortunately, this mechanism is not available to us. So wherein we have to go and give insulin into the subcutaneous tissue, wherein if they are short acting, they will be in monomers. If they are long acting, they are in hexamers. These have to get into the cells, gets into the circulation, gets converted into the monomers before entering the circulation. Thereby, it has to come into the cells. So there is a definite delay. So not the same action that of a indigenous or endogenous insulin production. So in modern medicine, we are trying to do, we are trying to mimic the body secretion. That is why a lot of formulations are born, as you can clearly see in this picture. We'll come to that a little later. So as I said, the exogenous insulin lacks both in the feedback mechanism and controlling intersection based on the changes in the blood glucose. So both continuous secretion and incremental postprandial secretion associated means all these are available to endogenous insulin, which is we don't get in exogenous insulins. So that is why we need to have our insulins which are produced exogenously, which has the time profile of the endogenous insulin. For that, we must understand what is PK and PD, pharmacokinetics and pharmacodynamics of insulin. In simple terms, pharmacokinetics is what the body does to the drug, and dynamics is what the drug does to the body. This is a simple way of explanation of pharmacokinetics and we are not pharmacy people, but at least these simple things, if we understand, we'll understand things much better. So the insulin concentration versus time is PK profile, and the blood glucose concentration versus time the pharmacodynamic profile. Now this is exactly what happens of insulin in its pharmacokinetics and pharmacodynamics. In practice, what is more important is the pharmacodynamic of molecules, which determines how the insulin works. And the gold standard to understand, to know the pharmacokinetics and the pharmacodynamics is the glucose clamp technique, which determines the pharmacodynamic and provides us valuable information with respect to the onset, peak, and duration of action. So glucose clamp study demonstrated that once daily administered glucose glargine and insulin provides effective glucose and reduces the risk of hypoglycemia excursion. This is exactly what we require basal insulin, just like what the body does it. Whereas the short-acting insulin, they're short and their pharmacodynamics are totally different. When we combine these two things, we almost get what the body mimics as far as insulin secretion is concerned. Now, if you look at the PK and PD of the human insulins versus the natural insulin available, look at that. The blue one shows natural response, which is faster. It rises faster. Whereas what we give exogenous insulin, though it is human insulin, it takes a long time and remains longer in the body compared to the. So the pharmacodynamics are little different between the. That is why we have a problem of delay in the onset of action of insulin. That is why we have to give these insulins at least 20 to 30 minutes before food so that it mimics exactly what the body does. And today scientists are trying to address this issue so that newer insulins which can mimic this time profile are discovered. Now, this is exactly what I have done. I don't want to go into the detail of that. So from the human insulins, we have now come to insulin analogs, which is about close now 20 years now. Somewhere 1990s, we developed that. These molecules are altered through genetic engineering and DNA technology in the PK and PD property. All the rapid-acting insulin analogs vary in the human insulin from human insulin by 1 or 2 amino acids. That's why the name Lispro, because they exchange lysine with proline. So this is the change of amino acid sequence which has changed the dynamics and the pharmacodynamics of the molecules, thereby faster action of the insulin. So these change of molecules have reduced the strength interaction that hold the insulin dimers together, allowing the faster dissociation of hexamers into the subcutaneous space and hence absorption of monomers. As I have told you earlier, everything is kept in hexamers. They have to be converted. And what these analogs have done is they have changed this dissociation to a rapid pace, thereby they are converted quickly into monomers, so the action becomes faster. I think that's what we need to understand mechanism of action of these insulins. Now, to go a step further, we have now what's available as ultra-fast insulin by the name FIAS, which contains insulin aspart formulated with 2 additional excipients, L-arginine and niacinamide. The L-arginine acts like a stabilizing agent, while the niacinamide accelerates absorption at the site of action. So, the onset of this injection is 5 minutes faster than the analogs that we already have. So it's definitely much faster than human insulin, definitely more faster than the analogs. So slowly we are going in the direction of the body which senses the glucose and immediately releases. That's exactly what we are trying to follow. So this is how ultra fast acting insulins work. Now coming to basal insulins, as we said, we want to mimic the body's mechanism. Body has both prandial insulin which is secreted and the basal insulin. Now, we require to mimic thereby giving both type of insulins. Thereby, these basal insulins are born, which refers to constant low level of insulin that is secreted to maintain stable glucose level between meals and overnight. Now, the main aim of basal insulin, and just like our body insulin, is to suppress hepatic glucose output, because liver should sense the presence of insulin, thereby suppress the hepatic glucose output, especially during the fasting state. And this mechanism is altered in type 2 diabetes. So we need basal insulin which can effectively suppress the glucose output. That is why basal insulins are always preferred as the initial treatment in type 2 diabetes, so that we can bring down the fasting blood sugar to near normal. Now, there are basal insulins. In the 50s and 60s, we had NPH insulins, which were intermediate insulins. They were crude insulin because of their pharmacodynamics. As years went by, as soon as 2000, we got very good insulins, which are truly basal insulins, which can work close to 24 hours and really work as basal insulin in the true sense. Not only this, beyond that we have gone further, and there is another insulin which is Degludec, which has come into the market, which has still better profile as far as the pharmacodynamics are concerned. So it works more effectively and works as much as 40 to 42 hours. We have a true basal insulins that are available. This is how that has been made by changing the molecular structure. Okay, and these are all when you inject this glargine, it penetrates in the acidic pH, and it turns out to be and fits into multiple hexamers, and they are tightly bound to each other. Hence, the dissolution takes place very, very, very slowly into monomers. That is why the action of this insulin is peakless, what we call. They don't suddenly come up. So these are otherwise known as peakless insulin. Thereby, we have achieved what we required in the body as basal insulins. Yeah, these are all the various timelines and action, onset of actions of all things all of us know about it. I don't think I should tell them. All that I would like to know you is these actions of the long-acting insulins are much higher, longer compared to the NPH insulin. That's why slowly NPH is going into disrepute, though of course the cost of it is much lesser compared to these newer insulins. These are the pharmacokinetics and pharmacodynamics of all many different insulins. Now look at this nasal insulin. It has a very fast onset of action compared to your even analog insulin. So it is a definitely better insulin. It is faster. It is in monomers and gets into the tissue very fast, and this is exactly what we need. So the technology is improved, and if it comes to the market, I think we should be happy to get it minus its side effects. Likewise, the various pharmacokinetics and dynamics of different insulins I have put there just for you to just know how they mimic in the body. I'm not going to the details of this. This is how when you mix the insulin, this is exactly what happens. You get both the desired effect of both basal as well as bolus insulins. I'm just showing this the graphs of all this. Yes. So at the end of this, now we have come to know that we are to a certain extent have become successful in mimicking the body's mechanism of operation. And if you look at this second graph, and when we combine most of these insulins, what we do in the practice, we are trying to bring both the basal insulin there as well as the bolus insulins. So technologically, we have successfully achieved something, though we have our own setbacks. Now, having said that, how are we going to start initiation of insulin? I'm only going to talk on insulins, how to initiate, that mainly on basal insulins. So normally in type 2 diabetes, I'm not talking type 1 diabetes, that's completely different. Type 2 diabetes, there's the insulin resistance, and we need to remove that insulin resistance by various mechanisms like weight loss, diet, exercise, and only when these don't work, we need to start on insulin. And the American Diabetic Association's initiation of basal insulin for those patients who are uncontrolled after 3 months of combination therapy, whose A1C is greater than 10%, whose blood glucose is more than 30%, or who are symptomatic hyperglycemia. I think that's a good recommendation by the ADA. I think that's exactly what we start in the practice. So initially nobody jumps and starts insulin because insulin is not the panacea for all the diabetic patients, except in few circumstances, especially in type 2 patients. The question is, why basal insulin? Now, if you look at this statement, it's a very interesting statement and a very important statement as well. Look at the relative contribution of fasting hyperglycemia A1 in C. It increases gradually as the diabetic worsens. So if you look at the A1C, if you have a very high A1C, it means to say the contribution of fasting sugar is more compared to the postprandial. So by looking at the A1C and fasting blood sugar, you can say this patient has got a fasting hyperglycemia, was not well controlled. Whereas a relatively well controlled patient is a postprandial excursion which is determines the A1C change. So there will be a small change which is always done in the postprandial excursion. So if you understand these two things, your treatment becomes very easy. So the basal insulin, which I have already told you, it reduces the hepatic glucose output and it affects on fasting blood sugar. It reduces the fasting blood sugar. I think that is where this A1C comes down. So that's why that adage, fix fasting sugars first by giving basal insulin. So that's why it makes sense to start basal insulin. So we are actually targeting hepatic glucose output and thereby reducing the fasting blood sugar. Once the fasting blood sugar comes to normal, what is available by reducing glucotoxicity will improve the postprandial blood sugar by itself. at least for some time. Now, how do you start basal insulin? The insulin should be started at 10 units per day or 1.1 to 0.2 units per kg per day. And the adjustment should be done 10 to 15% at least twice a week, not every day. So it is by 2 to 4 units once or twice weekly to reach the fasting plasma glucose to 100 to 130 milligrams per deciliter. This is a very wise, and of course you are continuing your other medication as well. So when we are going on giving that basal insulin, it does not mean it will work for a long time. It will work for a short time. But that since it is a peakless insulin, it will never look after the postprandial excursion. So don't be under the impression that insulin is the panacea to bring down all the blood sugar levels. No. You need a prandial insulin little later. Now, what is the best guide? Best guide is a basal insulin of more than 0.5 units per kg and a more than 50 milligrams per deciliter difference between bedtime and the next morning SMBG value known as bean value, or a absolute morning glucose should recognize as a potential over-basalization. Now, over-basalization should not be done because it by itself can produce hypoglycemia at a very, very different times of the day because you don't have control over it. So hence, a good rule is don't give more than 0.5 units per kg of basal insulin, or follow these suggestions so that you are giving an optimal basal insulin to the patient. Now, once the glycemic targets are not met and the postprandial sugars are high and A1C is not under control, you have no other option than to start prandial insulin. So a short-acting insulin initially has to be started on a large scale of that day, which can control postprandial excursion and continuing with his basal insulin. So this will for some time bring down his sugars, but if it's not better, we'll have to look at second meal also and then again give another prandial insulin. So now it becomes what is known as basal bolus therapy, and it is a very simple therapy. If we understand the mechanism and pharmacodynamics of these insulins, you can beautifully target the patient. One word of caution is during this basal and bolus therapy, it's better that we avoid secretagogues like sulfonylureas because it itself can produce insulin secretion, whatever remaining, and can produce hypoglycemia, which you have no control on. And if the patient has concerns, we have to look at the premixed insulin as well. Now, the problem, of course, this is exactly what I have told you. I have put it in a nutshell. It's a beautiful algorithm. How do you start? You don't look at these two things, but only look at this, how you start. Okay? Algorithm, it is given. I have given the reference for that also. Okay? This is the continuation of the same thing which I have told you. How do you improve and adjust the insulin? Okay? So, care has to be taken that the patient should not develop hypoglycemia. So it's wise thing not to bring down the blood sugar to less than 100 fasted. It's always better that we look at once at least 3 AM blood sugar so that we'll understand whether we are over-influencing them or under-influencing these patients. Okay, another algorithm from the European Society, I think those are, either way you can select which you feel they're all right. These are the titrations that are available to us. Now the problem of insulin is we have an inertia. This itself is a big subject. Both clinicians as well as the patients have the inertia to start insulin. So we'll wait too long before we start on insulin because as clinicians or health workers, we don't have too much time to spend with the patients. Counseling becomes difficult and we are also scared of the hypoglycemia, and patient needs to be monitored very regularly. So there is always the inertia that we postpone the insulin. As far as the patient is concerned, they have their own problem. They think insulin is always prescribed at the end of their life. They have fear of the insulin injection. If they develop hypoglycemia, they will never go back to insulin. And it has its own social implications. taboos. So there are a lot which requires a good counseling before we start insulin, because once we start insulin, then the next question is that when are you going to stop insulin? And most of us know once we start insulin, we cannot stop insulin. So I think it is worthwhile spending a lot of time with the patient before we even start insulin. Otherwise, of not worry. Now the newer, because there's a lot of production of insulin, to bring down the cost, a lot of bioequivalents of insulins have come. Thereby they can compete with the industry can compete with each other. But before that, two insulins have to be properly matched for their efficacy. That's why this graph is put there. Now, before I conclude, there's a very interesting thing which I just read. Does sunlight has any effect on the insulin action by acting on the hypothalamus? Very interesting topic, which has just come into the literature by various mechanisms, which those who want to read about this, this is the article that is available in the net. It has just been released in 2020. Insulin under the influence of light. So we cannot say that there are so many factors which affect the insulin actions, right from the site of injection, the temperature, the stress, the hormones, so many effects. So now they have discovered one more, that is the influence of light on the action of insulin, which is in its infancy. Those article is a very nice article to be read about, so it may give some light about what exactly it talks about. Okay, these are basic references. Rest of the references I have given in my slides, and this is the end of my talk. Hope I have been to the audience as far as insulin action and why do we pick on basal and dose insulin. And thank you very much, Omnicures, for having given me this opportunity to talk to you. Thank you very much.